Namaskar. Hi friends, welcome on our channel. This video is intended for healthcare professionals only. Sacrectomy is indicated for malignant as well as benign bone tumor of sacrum. Chordoma is most common malignant tumor and indication for sacrectomy. Here we present planning and surgical steps for combined anterior and posterior approach for sacrectomy at S2 level. One challenge during sacrectomy at this level is saving S2 nerve root as it traverses from S2 foramina at lower border of S2 where our plane of osteotomy will lie. However, same has advantage also, as if we can save bilateral S2 nerve roots, there are around 50% chance that patient will have normal bowel bladder function, and even if we save only one-sided S2, there is 12 to 25% chance that patient will have normal bowel bladder function. So upfront colostomy is avoided and is performed later on only if required. We had a 62-year-old lady with sacral chordoma. This was the disease extent on MRI. It was going up to the lower part of S3 vertebra. Intracanaliculaar part always goes proximal to intraosseous part, which we should keep in our mind while planning resection level. In flat bones, we cannot precisely measure resection level in centimeters from disease or any bony landmark. So we have to plan our resection at some bony landmark, which will be lower border of S2 through S2 foramina in this case, which will provide us adequate intraosseous and intracanalicular margin. Anterior approach. When sacral resection is done above S3 level, combined approach is advisable. Aim is to dissect off rectum from the tumor till S4 or S5 and laterally till sciatic notch. Ligate posterior branch of internal iliac or whole internal iliac and put a mop between tumor and rectum. Mop will guide us a plane of dissection during posterior approach. If colostomy is planned upfront, it is done during this part of surgery. Posterior approach. Patient is positioned in 90-90 position, in which hip and knee are flexed at 90 degree, and this avoids increased intra-abdominal pressure during jackknife position, which may hamper venous return and cause increased venous bleeding. For orientation, this is cranial part, this is caudal part, where we have to seal off our field of dissection from anus. This is left where operating surgeon will be standing, and this is patient's right side. Midline incision is taken islanding out biopsy scar and taking thinned out skin as margin. For orientation, here is S2 spinous process, and this is how sacrum will lie in this patient. First structure that will be seen after skin and subcutaneous tissue is gluteus maximus muscle, which arises from sacrum and iliac crest and will insert on femur. In our case, left side gluteus maximus is partly infiltrated by tumor. So on left side it is sanctioned away from the sacrum, and on right side near the sacrum. Release the pressure of retraction on skin flaps in trim. Ligashore may be more useful cutting this muscle. Gluteus maximus will lie all along our field as it is large muscle and covers whole gluteal region. Once all gluteus maximus is cut, 6 important structures will be seen, 3 facial and 3 neuromuscular. First, sacrospinous ligament, which lies between sacrum and spinous process of pelvic bone. It is narrower than sacrotuberous ligament, again showing sacrospinous ligament. Second is sacrotuberous ligament, which is broader and thicker and lies between sacrum and ischial tuberosity. It is cut under guidance of finger or artery forceps, taking care not to injure deeper structures. Third facial structure is anococcygeal fascia, which lies between coccyx and anal canal, which forms the floor of pelvis. Sanctioning of it is also done layer by layer and always guided by finger. Amongst 3 important neuromuscular structures that we need to identify, the first is piriformis muscle, which originates from anterior surface of sacrum and inserts on piriformis fossa of femur. It is cut with long mixture forceps going underneath the muscle. Inferior to piriformis, 5 nerves exit greater sciatic notch. From medial to lateral, they are pudendal nerve, nerve to obturator internus, inferior gluteal nerve, posterior cutaneous nerve of thigh, and sciatic nerve. Inferior gluteal nerve is second important neuromuscular structure that we need to identify. It lies between pudendal nerve medially and sciatic nerve and posterior cutaneous nerve of thigh laterally. Once it comes out, it runs laterally to supply gluteus maximus muscle, whereas posterior cutaneous nerve of thigh and sciatic nerve runs down distally into the thigh. This direction of nerves helps identify them. However, sacral tumors with resection at lower border of S2 are usually small enough that we don't have to extend our lateral dissection up to the sciatic nerve or posterior cutaneous nerve of thigh, so as in this case. Nerve to obturator internus is very small and difficult to identify sometimes. Third, pudendal nerve, which comes out of pelvis to wind around the ischial spine and goes back into the pelvis. We are seeing that small extrapelvic part of nerve now. Pudendal nerve is made from S2, S3 and S4 nerve roots. We are sacrificing S3 and S4 nerve roots of pudendal nerve. So pudendal nerve will be seen as a continuation of S2 nerve root, which we are saving. Again, showing inferior gluteal nerve and pudendal nerve. Pudendal nerve will guide us our plane of dissection, which will be medial and posterior to it. Once we dissect in this plane, MOP will be palpable, which was put during anterior approach. It will guide our further dissection. Superior gluteal nerve and vessels exit greater sciatic nerve superior to piriformis muscle and remains lateral to our plane of dissection in this case. Now we will move towards osteotomy of sacrum. Let's first understand relevant anatomy. SI joint is formed by S1, S2 and partly by S3 vertebra. So, sacral dissection at S2 will entail sacrifice of some ilium and SI joint even if it is not required as margin. Plane of osteotomy remains transverse till it reaches SI joint and after that it steps down as ilium is not required as margin. First identify S1 spinous process and track down S2 spinous process. Cut S2 spinous process. Dorsal S2 nerve roots are cut and S2 foramen is identified and confirmed under CM guidance with K-wire or artery forceps inside it. Laminectomy is performed with rongers or bone scalpel. S2 nerve root will be seen exiting laterally and filum terminale with rest of the nerve roots going down. Filum terminale with rest of the nerve roots is ligated and cut. S2 nerve root is retracted proximally and osteotomy is done transversely. Same procedure is repeated on opposite side. Once osteotomy reaches SI joint, it steps down and exits in the upper part of greater sciatic notch. This is how ventral S2 nerve roots will be seen after laminectomy. These are distal nerve roots with filum terminale which are cut after ligation. Again, demonstrating proximal retraction of nerve root and osteotomy. Specimen is mobilized and rest of the soft tissue attachment is cut and specimen is delivered out. After resection, this is how S2 nerve roots and osteotomy will look like. Again, showing osteotomy and nerve root. Bone edges are covered with bone wax to prevent bleeding. After hemostasis, plastic surgery team walks in for flap. In this case, local rotational flap was done, and this is how it looks like after closure. Rehabilitation. Patient is allowed log rolling initially, followed by standing and walking as guided by wound healing. But sitting is allowed only after adequate wound healing. Gluteal, core and back muscle strengthening exercises are started accordingly. Patient may have some bowel bladder incontinence initially, but it usually improves with time. So it is better to wait for at least 6 to 12 weeks and decide for need of colostomy or condom catheter or other measures to manage altered bowel bladder function. Residual or recovering anal tone is a good sign post-operatively. Post-operative X-ray showing cut at lower border of S2. Patient is able to sit on floor, squat and walk normally within couple of months. Thank you friends for watching this video. Please subscribe our channel for more such videos related to orthopedic oncology procedures, education or patient information.